Good morning, everyone. Welcome to Grand Rounds. Hope everyone had a restful and safe long weekend. We'll get started and I'll turn it over to Dr. Warmer to introduce Dr. Chan.
Hi, good morning, everyone. Welcome to this morning's installment of our ongoing virtual Grand Rounds series. This morning, we're very pleased to welcome Dr. Lili Chan. Dr. Chan earned her medical degree from Drexel University College of Medicine and completed residency training in internal medicine at Rutgers University Robert Wood Johnson prior to joining Mount Sinai as a fellow in the Division of Nephrology. She currently serves as an assistant professor in the division. In addition to her clinical work caring for patients with all stages of renal disease, Dr. Chan's research focuses on the uses of big data to identify ways to improve outcomes for patients with renal disease. A very warm welcome to Dr. Lili Chan.
Thank you. Good morning, everyone. I'm just going to share my screen. And I'm hoping everybody can see that. Thanks. So today we're going to talk about COVID-19, which has kind of been the talk, unfortunately, of the entire year plus now, and specifically about how the kidney is affected by COVID-19. I have no disclosures. And so our three main learning objectives today is to talk about how AKI occurs in hospitalized patients with COVID-19, the development and performance of prediction model for acute dialysis, and also why it's important, and also about outcomes of hospitalized end-stage kidney disease patients with COVID-19. So when this all first started, we really thought this was just going to be a pulmonary virus, and that's how it was described and reported to WHO. But we quickly learned that it was so much more than that. It has essentially at this point been described in nearly every organ system. And as nephrologists, we're going to really be focusing on the kidney today. The ACE2 receptor is what the SARS-CoV-2 uses to enter into the cell, and ACE2 is present in pretty much every organ system, but more so in the heart, kidney, lung, and liver. And so there is thought that the virus itself can get into the kidney, and ACE2 receptor actually is expressed throughout the different portions of the kidney, including the glomeruli, the different podocytes, and also the tubule. And so this gave us concern as how much is the kidney going to be damaged by COVID-19. And this is also a nice figure that kind of summarizes, on top of direct viral infection, all the potential mechanisms that AKI can occur in patients with COVID-19, from simple pre-renal, because of increase in sensible losses, not feeling well, to also acute tubular injury in patients who have chronic sepsis and hypotension, and also concerns for different types of glomerulonephritis also, including collapsing GN, membranous, and minimal change disease. And so this was kind of surprising when the first reports came out of AKI incidence in different populations. In China, it was only reported to be 0.5 to 25%, in Italy, 28%, and in the first report in Seattle, it was only 19%. And this didn't really match with what we ourselves were experiencing here at Mount Sinai. This is actually a New York Times article reporting how we actually were at a shortage of dialysis. And even people taking to social media, and Dr. Oz reported asking for help and volunteer nurses to come and help perform dialysis because we were so short-staffed. And we ourselves saw probably at least a 50%, if not more, increase in the number of patients that we were consulted on. We had to deploy actually a new fellow and attending to cover the ICU service. We also had to really triage our patients for dialysis. You would see that we increased our use of potassium binders during this time because of the increased patient load, and also because many of our nurses were also on quarantine and sick themselves. And so this led us to perform this study where we wanted to look at the incidence of AKI in patients who are hospitalized with COVID-19 in New York City, since what is reported wasn't matching with what we were seeing. And this is work done with MSCIC data during the first surge for patients who were hospitalized from February 27th to May 30th, and the data was frozen at June 2020. We defined AKI using the KDIGO criteria, so anybody who had an increase in 0.3 milligrams per deciliter or a 50% increase above baseline. And so we excluded patients who were in the hospital for less than 48 hours, patients who had end-stage kidney disease, patients who had transplants, or patients who didn't have any creatinine value. And this resulted with 3,993 patients. At the time, because we only had a 30-day follow-up before a subgroup of these patients, not all of them were discharged. But even so, AKI was reported in about 46% of all of the patients that we were included in the study. And these are the different characteristics of patients who had AKI and who did not have AKI. And what I really wanted to highlight was that the AKI patients were older, and they had also more comorbidities of hypertension, congestive heart failure, and diabetes, which simply indicated that these patients who developed AKI were sicker at baseline. They also had higher white blood cell count and also lower albumin, which indicates that there was probably higher inflammation in the patients who developed AKI. We also categorized them into the stage of AKI. Was this simply all AKI stage 1 with a small increase in creatinine? But that's not what we found. About 30% of patients had stage 1 AKI, which is here in the blue. Stage 2 is here in the green. And then stage 3 is the purple and the green over here, separated by whether or not they did not need dialysis or whether they did need dialysis. So overall, of the AKI patients, about 19% of patients require dialysis. And we did see that the patients who were admitted to the ICU were more likely to require dialysis, with reporting more than 30% compared to those who did not who were not admitted to the ICU. We also tried to figure out what patient characteristics were most indicative of stage 3 AKI, the most severe form of AKI, and as expected, chronic kidney disease was kind of the front runner. As we know, there's a tight association between chronic kidney disease and AKI, and also potassium was, but this is likely a result of the AKI rather than an actual risk factor for it. And what's interesting here is we looked at the creatinine trends of patients during the first 14 days of their hospitalization, and this is categorized by whether or not they recovered their kidney injury at the time of hospital discharge. And what I really wanted to highlight was that those who did recover tended to have a more mild form of AKI, while those who did not recover had much higher levels of creatinine, and this was consistent throughout their hospital stay. And when we wanted to look at the different outcomes of patients with AKI and no AKI, AKI patients were more likely to require ICU admission, receive mechanical ventilation, and use vasopressors. And this is likely indicative, again, that the patients who did have AKI were simply sicker during their hospitalization. Length of stay was also longer, and likely because of the need for dialysis and transitioning from inpatient dialysis to outpatient dialysis. And mortality was 4 times higher in patients who had AKI than patients who did not have AKI. And this is quite a large difference. This is the Kaplan-Meier curve, again showing the non-AKI and the lower survival of patients who did have AKI, and remembering that there were differences in demographics and comorbidities between those who had AKI and didn't have AKI. We did adjust for that, and patients who had AKI had a 9.2% increased risk of mortality overall, and then if we look at the ICU patients, it was even higher, 11.4. And so you might ask, well, is this any different than non-COVID AKI? Is it just the same numbers, but just more patients? And so we didn't do this, but this was a study out of the Yale hospital system. And they compared 22,000 patients, 2,600 of which were COVID positive, and then about 20,000 of which were COVID negative. And they found that the incidence of AKI was 31% in COVID positive versus 18% in COVID negative. And they also, taking into account the differences in demographics, comorbidities, and also laboratory and vital signs, they found that in their fully adjusted model, COVID positive was associated with an increase with a 40% increased risk of developing AKI compared to the COVID negative patients. And they also looked at mortality, whether or not patients with COVID AKI died faster than patients with non-COVID AKI, and that was true. True, with the red line here being survival of the COVID positive, which was lower than COVID negative patients, remembering both groups with AKI. And going back to, the different potential mechanisms of AKI that from this figure, was this really just all pre-renal and acute tubular injury? So we also looked at a subgroup of patients within Mount Sinai who had urine studies measured. Those are only 656 patients. And we found that just regardless of whether the patients had AKI or did not have AKI by creatinine criteria, there were marked abnormalities in their urinalysis with high rates of hematuria, leukocyturia, and also proteinuria. And this is another study out of China, which reported similar things. And what is interesting is they selected a group of patients who did not have AKI by creatinine criteria. And this is a rather small number, which is 83. But even then, without any AKI on creatinine throughout their hospitalization, 54% of these patients had some form of urinary abnormality. And this included proteinuria and hematuria. And what was most interesting is they looked at these different markers of COVID-19 severity. Again, there was no differences in patients who had abnormal urine versus normal urine in regards to their serum creatinine, because these patients neither of these groups of patients had AKI. But what they did find was looking at the liver injury markers of ALT, AST, alk-phos, and LDH, that those who had abnormal urines were actually had higher levels of liver injury markers and also higher level of inflammatory markers, including CRP, ESR, IL-6, and serum ferritin levels. So what's actually going on in there? So we didn't do a lot of urine microscopy or urine sediment evaluation during this time, as it was really unclear whether or not urine was potentially infectious or not. It has been reported in about 10%. SARS-CoV-2 RNA has been detected in about 10% of urine from other studies. So this is a study out of Louisiana, Ochsner Institute, and they looked at the urine sediment of 20 patients with COVID. And predominant finding really was granular casts, which were muddy brown casts. And these are just some images that they included with different types of stain. And they also did a deep chart review to figure out, well, what was the cause of the AKI? And the predominant was acute tubular injury. And they also reported a couple of cases of collapsing FSGS, proliferative GN, and then a couple that they couldn't necessarily identify. And so I mentioned collapsing FSGS. What is that? It's a variant of focal segmental glomerulosclerosis, and we most often see it described in patients with HIVAN. And unfortunately, in idiopathic collapsing FSGS is predominantly present in African patients with African ancestry. And we now know that this type of collapsing FSGS is more common in patients who have this APOL1 gene, high-risk gene mutation. And where if you have normal, then you're susceptible to the African sleeping sickness, trypanosome infection. But if you actually had one of these high-risk gene alleles, then this is actually protected against trypanosomiasis. But if you have two of the high-risk gene alleles, then you have an increased risk for chronic kidney disease. And so we actually had a patient who was admitted back in April. She was 53, you're a female who was African-American. She had hypertension, obesity, obstructive sleep apnea, and her admission was for COVID and COVID-19 and AKI. And these were her labs on admission. Her creatinine was 6.1, her BUN was 71. Her albumin was 2.2, and her protein creatinine ratio was 21.7. Her serologic workup was essentially negative. And so we did a biopsy on her because she had this massive amount of proteinuria, and she was on dialysis at that time because of her kidney failure. And this is her biopsy results, which essentially shows this collapsing FSGS, which is notable with the collapse of the capillary lumens, which is here and over here, and along with hyperplasia of the epithelial cells. There's just two glomeruli with different types of stain showing the same thing. And subsequently, she was genotyped, and she was found to be homozygous for the G1 APOL1 allele. And this also has been reported now with several case series out from different institutions. And this is just 6 different patients who also had the APOL1 high-risk genotype, again, all showing this collapsing FSGS. The capillary lumens are closed with hyperplasia of the epithelial cells. And so you might ask, well, going back to this slide, if ACE2 is present in the kidneys, is there actually a virus that has been found in the kidney? And so this is actually the visual abstract from 4 different studies that have looked at autopsy samples and also kidney biopsy samples. And of these, they have not found any SARS-CoV-2 using immunohistochemistry staining. And they looked at EM. So there's some people who have found these viral-like vesicles, and they would say that this is actually the SARS-CoV-2, while on the other hand, people also report these vesicles and say, well, these are not viral, they're viral-like, but they could be simply things like clathrin-coated vesicles or podocyte endocytosis with subsequent formation of intracytoplasmic microvesicles that resemble virus. So it's kind of remains to be shown whether or not if their virus is detected in this. So summary number 1, AKI is common in patients who are hospitalized for COVID-19. Urine abnormalities are common in patients even when creatinine may be normal. And whether or not this is just subclinical AKI, it's very likely. So I do encourage you to check urine in patients who are admitted with COVID-19 because you may end up finding abnormalities that you weren't necessarily thinking about. And this did associate with different other markers of COVID severity. Patients of African descent are at high risk for AKI due to their APOL1 genes, and we currently still aren't sure whether or not SARS-CoV-2 is present in the kidney. So how much of this AKI ends up recovering? Do we really have to worry about this, or is this simply something we need to think about when these patients are hospitalized? So we also looked into that. Of the 832 patients who survived to discharge, about 2/3 of patients did recover kidney function, and while the remaining 1/3 did not recover kidney function. And we define recovery as a difference in creatinine of less than 0.3 or a change in creatinine that was less than 25% at hospital discharge compared to their baseline creatinine. And we also looked at the subgroup of patients who, by the time we were doing our study, actually had additional creatinine values on hospital follow-up, and this was a median of 21 days after hospital discharge. And while it was a smaller subgroup, it was only 212 patients at June. The people who did not recover at hospital discharge, an additional 1/3 of patients did recover their kidney function, but 2/3 of patients still had continued abnormalities in their creatinine. And also interesting is of the 2/3 of patients who did recover their kidney function at hospital discharge, about 14% of patients now again had increases in their creatinine levels. And this is just looking at why we care is patients who may or may not have kidney disease and develop AKI, there's 4 ways that can on outpatient can happen is they to have a full recovery of their kidney function. This AKI is now going to lead to new chronic kidney disease. It can lead to worsening of their chronic kidney disease, and they can now end up on dialysis. And this is some data from Assess AKI, which is this prospective hospitalization cohort, which looks at development of chronic kidney disease and progression of chronic kidney disease on the left, separated by whether or not they had AKI during the hospitalization. And as you can see, patients who did have AKI during their hospitalization was more likely to have new onset chronic kidney disease compared to those patients who did not have AKI. And even of patients who already had chronic kidney disease, AKI worsened chronic kidney disease compared to more than patients who did not have AKI. But of note, looking even at those groups that did not have any AKI, at least by creatinine criteria, the rates of progression were still pretty high. Incidence CKD also was higher. So it's simply being in the hospital because of acute illness is also a risk factor in and of itself. And so in order to kind of follow up what happens to our patients, we are performing a long-term outcome study of looking at patients who are discharged from the hospital with COVID-19, and we'll be collecting blood and urine samples. And in patients who have a clinically indicated biopsy, we're going to do additional single-cell sequencing as proteomics analysis in hopes of identifying patients, creating a risk prediction model where we can identify patients who are at higher risk of developing a kidney outcome, whether that be progression of CKD or end-stage kidney disease on dialysis. And so I know we're all dealing with the second surge of COVID right now, and just looking back at how has AKI changed from the first wave to the second wave. And so again, working with MSCIC data, we're looking at patients who were admitted between March and the end of 2020, December 31st. Again, AKI defined the same way as our first study using the KDIGO criteria. And so this is actually the different months since March to December. The pink line here indicates the number of hospitalizations. And then this is the blue columns are the percent of hospitalizations that have AKI. So again, it was quite a lot high when we were dealing with it during March, April, and May, which was that first surge of the 40%. And it quickly tapered off into about 20% and has stayed consistent around there. And you might also ask, well, how many of these patients are still requiring dialysis? Has that changed? So again, hospitalizations is the line, percent of hospitalizations that had AKI in the light blue, and then percent of AKI that had required dialysis in this dark blue. And interestingly, while November, December numbers do seem to be lower for dialysis, they were pretty consistent for those months otherwise. And unfortunately, we still don't know what led to these differences and changes in AKI and dialysis, whether it be the differences in the case mix of the patients versus potential differences in treatments that we've now instituted throughout the hospital. So again, we're just reminding you, everybody, of how difficult dialysis was to obtain. Many of you participating in the care of those AKI patients remember us throwing high-dose diuretics at patients, potassium binders at these patients because we simply weren't able to provide dialysis because we were so short-staffed with that. So it's important actually for us to be able to figure out early on in the hospital course which of these patients are going to ultimately require dialysis. So again, using MSCIC data, looking at patients who were hospitalized from March to July 1st, we tried to build different models to see if we could predict which patients would require dialysis. And we used 4 different approaches: logistic regression, which is kind of our standard model; lasso, which helps us with variable selection, given the potential numerous features for inclusion. And we also used 2 machine learning approaches, random forest and XGBoost. So random forest and XGBoost are both machine learning models that utilize a decision tree. So for random forest, this is an example of how it would work. So at each node is a feature, and at each branch is the result of that feature. So let's say diabetes, yes versus no, and then each feature then trickles down, and this results in a prediction for that patient. And this is done multiple times, and then we average all of these predictions, and you get the random forest prediction model. And this is kind of done in parallel while XGBoost is done serially. And so we use data from Mount Sinai Hospital as the training and internal validation, and then we did external validation in the 4 other Mount Sinai Health System hospitals. We included patient demographics, comorbidities, vitals, and labs results from the first 12 hours of hospital admission. We only included patients who were over the age of 18 who had a documented SARS-CoV-2 test. We excluded patients who were end-stage kidney disease and who were admitted for more than 48 hours before the test was performed. And they had to have features, and patients were only included if there was less than 30% missing. And we did prediction for different time periods: day 1 of hospitalization, 3, 5, and 7. And so this is the results of our model. We did the lasso, logistic regression, random forest, XG imputed, and XGBoost non-imputed, meaning imputed for the missing features that were included in the different models. And so I just wanted to really highlight that this is, again, for the different timeframes, day 1 and day 3, that the XGBoost non-imputed had the best area under the receiver curve, and also the best area under the precision recall curve. AUPCR may be better because there's a class imbalance, and so only a small percentage of patients did ultimately receive dialysis compared to the entire COVID positive population. And this model tended to perform the best in also the day 5 and also the day 7 time periods, with obviously performance being lower for longer longer time from hospital admission, because remember, these were based off of vitals and labs during the first 12 hours of hospital admission. And this is a Shapley plot, which looks at the different features, the top features that contributed to the most to driving the model prediction towards hemodialysis. So here, if you can tell that there's individual dots here with red indicating that the number is higher. So the creatinines were higher here compared to the creatinines that were here. And this is whether or not it's pushing the model to point more towards dialysis. So a higher creatinine would push the prediction model to say that yes, this person will require dialysis, versus a lower creatinine value, which was pushing the model to say no, this patient will not require dialysis. So this is just for the day 1 prediction model, but these were very similar to the day 5, 3, 5, and 7 models. And what was nice to see is that the features that were included and were top contributors really made sense to us. Creatinine, their pH, their blood pressure, CRP, and calcium levels, which were all clinically at least made sense to us. And so summary number 2, a third of patients at discharge do not recover kidney function back to baseline. And incidence of AKI has changed over time, actually improving, although we still don't really completely know what accounts for these changes. We did develop and validate a machine learning model that accurately predicts HD prediction over different time periods. And again, those factors that were contributing strongly to this model made clinical sense to us. And we're actually have been silently testing this model to see how it performs prospectively. And we're hoping to deploy this model into clinical care soon so that we can help better risk stratify these patients on hospital admission. So I've talked a lot about acute kidney injury. I wanted to switch gears a little bit and talk to our other vulnerable population, which is those of our patients who are on dialysis. And so many of you who can help with our care of our dialysis patients will actually recognize this. This is a pretty standard looking dialysis patient. Our patients tend to be of the older age group. This is looking at the United States Renal Data System breakdown of age, and 88% of our patients are over 45. Many of our patients are actually over 75 and 65. And they really, during this pandemic, are particularly vulnerable because they're not able to socially distance. This is pretty similar to what a dialysis unit outpatient dialysis unit would actually look like. Dialysis machines and chairs, and you can see that these might just be 6 feet apart. Many of them share a transportation. They might take the same assessor ride as other dialysis patients, so they're exposing themselves not just to other patients, but also to the drivers. They have to attend dialysis sessions usually at least 3 times a week. And on average, they already get hospitalized 1.7 times a year. So they were getting hospitalized during the COVID surge and exposing themselves to the emergency room and other patients there. Again, this is a study from China that was reported early on that looked at how many of their patients, all their patients, and medical staff was actually screened for COVID, and they found after one person was COVID positive, ultimately 18% of these patients were diagnosed with COVID. 3 of them had to go to the ICU. 24% of these patients died. And this was a study where they looked at all of the PCR and also antibody test results of patients, of in-center hemodialysis patients from 376 patients, PCR positive, PCR negative, and no PCR ever done, indicating that no PCR, they were never symptomatic, so there was never suspicion for patients to get tested. And what I really wanted to highlight was look at that even though these patients were never symptomatic, nearly 20% of patients were antibody positive, and that there's likely asymptomatic spread in these patients. And this was a study down out of Colombia, which just down the road from us, and they looked at the different symptoms on admission, and they found that only about 50% of patients had a fever, only 40% had a cough, and only 30% had dyspnea, which is not the classic symptoms well, these are the classic symptoms we expect to see, but they're not getting reported as much in these dialysis patients. And in another study that of critically ill patients who are admitted to the hospital that I didn't include in this slide deck, the most common symptom that patients on dialysis and COVID had was actually altered mental status, which was, again, not something we would normally contribute necessarily to COVID. And they looked at what happened to these dialysis patients. Ultimately, 31% of them died. Unfortunately, in their study, they didn't do any matching or look at the non-ESKD end-stage kidney disease population. So it's hard for us to see from their study how this compares to their non-dialysis cohort. And so it kind of led us to wonder, is this all because of age and comorbidities? Because we know our dialysis patients are older and tend to have a higher comorbidity burden than the non-dialysis patients. And so we did a propensity matched analysis looking at 122 dialysis patients who were admitted from March to June 7th. And we matched them by age, gender, race, ethnicity, comorbidities, body mass index, which hospital they were admitted to, and also the week of hospital admission to 610 non-dialysis patients. And we, even after matching this, we did propensity matching, that our dialysis patients still had a higher comorbidity burden, significantly higher rates of diabetes, congestive heart failure, and hypertension. Admission symptoms were actually similar between those on dialysis and those who were not on dialysis. There was no significant difference. While we did find significant differences in some vital signs of blood pressure, heart rate, and pulse oximetry, I think clinically these are pretty small differences, except for maybe the heart rate, which is about a 10-point difference. And we did also find that the dialysis patients had a lower white blood cell count and a lower hemoglobin, but we expect the lower hemoglobin because these patients are on dialysis and are dependent on ESAs. And we also looked at the 6 different inflammatory markers: CRP, ferritin, D-dimer, fibrinogen, interleukin, and procalcitonin. These are log transformed. And we found that dialysis patients, which is the orange here, had higher ferritins and also higher procalcitonin levels, while there was no statistical difference in the 4 other inflammatory markers. So even though after matching, our dialysis patients had more comorbidities, this is looking at the outcomes of these patients, and we did not find a statistical difference in need for mechanical ventilation, ICU admission, or mortality. And in fact, there was a statistically significant difference in that our dialysis patients were less likely to be admitted to the ICU, which actually led us to think, well, is it simply because, well, our dialysis patients are older, they do have more comorbidities, were they not getting accepted to the ICU more often, were they made DNR or DNI sooner rather than the non-dialysis patients? And we did chart review of our dialysis patients and non-dialysis patients, and we didn't find any difference in that in code status or hospice utilization either. And this is the unadjusted and adjusted results for our different outcomes. And even after, because we still had, again, differences in their age and the comorbidity burden, even after adjustment, again, we didn't really find a significant difference in mechanical ventilation or in hospital mortality, but ICU admissions were lower in our dialysis patients than our non-dialysis patients. So this kind of leads us on to from outpatient, moving on to the outpatient dialysis world. Our dialysis patients in general have a lower response rate to vaccines, especially for influenza vaccine. The uremia leads to an altered immune response. So we don't really know how quickly are these patients now able to shed the virus or how long they're going to continue to have viral shedding, and will they develop antibodies? Currently most dialysis units protocol and also our current recommendations for our patients is to quarantine for 10 to 14 days. Is that enough if you're already immunocompromised? And so this is work out with Dr. Aisha Sheikh from the Bronx VA and looking at 85 dialysis patients and in-center hemodialysis patients. And they all had one nasal or nasopharyngeal SARS-CoV-2 RNA test done. And if they tested positive, then they had repeat testing done. Antibodies were drawn at 2-week intervals at resolution of symptoms. So on their screening, 21% of patients did have COVID positive. All of the patients were symptomatic except for one who tested positive and was asymptomatic from the nursing home. And this is just a volcano plot looking at gender, race, comorbidities, and dialysis access. And again, really no difference between those who were COVID positive versus COVID negative. Note that because this was a VA cohort, the percentage of males was very high. And what was interesting is this is the result of the antibody, this is the result of serial PCR testing done. A positive test is the purple, a negative test is gray. And each black line here indicates when the test was done in relation to the first COVID test. So this is 20 days, and at 20 days, 68% of the dialysis patients continue to test positive for SARS-CoV-2 RNA. And what's even more interesting is that 5 patients who did have 2 negative tests subsequently ended up having a positive test. Again, it's unclear whether or not this RNA is just, leftover virus that the body has already eliminated, or if this is still potentially infective. But there is definitely much longer presence of it than we initially anticipated. And this is the result of the antibody testing. This was the Abbott IgG nucleocapsid antibody test, where 1.4% was considered to be positive. So luckily, all of the 19 patients who had antibody testing done were considered to be positive. And this was the different 1, 2, and 3, and predominantly the third antibody continued to increase over time. So summary, 3 are hospitalized. Dialysis patients have similar outcomes to matched non-end-stage kidney disease patients, which suggests that age, race, and comorbidities are drivers to differences seen in COVID-19 outcomes. SARS-CoV-2 RNA is detected over 20 days after the initial positive swab in over half of the patients. And luckily, all of our dialysis patients did develop antibodies. I can also tell you we're starting also to look at how our dialysis patients will be responding to the vaccine. The VA has, I believe, started to vaccinate patients, and we'll be able to see whether or not patients will form antibody response to the vaccine also. So that's coming shortly. So, where do we go from here? I think we've learned a lot so far about AKI and ESRD, but there's still so much more to learn. And I think this pandemic has really increased discussions on social determinants of health in our dialysis patients and even really our patients in general. Again, noting that patients who are less social are more socially economically challenged are more likely to take high-risk jobs, live in close housing quarters, which is going to increase their transmission rates and also put them at risk for different exposures. And this is just the 7-day positivity rate by zip code for New York alone. And you can already see that there's marked differences in where you live and whether or not you're going to contract COVID. And just bringing us back to that, our dialysis patients are particularly vulnerable because they need transportation to their dialysis units. They're not able to isolate because on top of going to their dialysis units, they see different doctors, they see their primary care doctor, they see the vascular surgeon for their vascular access. They have to adhere to a very restrictive diet. They salt restrict, they fluid restrict, they potassium restrict, they phosphorus restrict, which can be very difficult to do if this is what your grocery store looks like. If there's no access to fresh food and the lines are really long. And so we're actually partnering with the Renal Research Institute to look at the the Renal Research Institute is the research branch of Fresenius, and Fresenius is the largest dialysis provider across the world, actually. And we're going to combine our patient cohorts, which is going to be about 1,000 different patients. And using their addresses, we'll perform geospatial analysis, meaning we're going to look at their addresses and identify these different neighborhood and also personal social determinants of health. Building, money, education, food access, healthcare access. And we want to see whether or not these different social determinants of health actually has an impact on patient hospitalizations and also in hospital mortality. And then we're going to combine outpatient data with their inpatient data. Outpatient data, meaning our dialysis patients, they get monthly blood work done, CBCs, BMPs, albumin. They have also their vital signs are measured almost every 15 minutes at their dialysis sessions. And so we're going to combine that outpatient data, which is highly granular, also with their inpatient data, what happens while they're in the hospital, and along with the social determinants of health. And then we're going to build different risk prediction models to see if we can classify these patients into low, medium, and high risk for adverse outcomes from COVID. And so I kind of wanted to end my presentation with a quick summary of, how quickly things have progressed. Back in December 31st, 2019, that was when the WHO was first notified about several pneumonia cases, and our science has really just progressed so quickly with the first vaccine given in a non-clinical trial in December 8th, 2020. And even though we've come so far, there's still a lot of questions that still remain. What happens to our AKI patients when they are discharged? What really is the mechanism of COVID AKI? It sounds like there's multiple different ones, but the pathways have still remained to be determined. What are different risk factors for AKI and dialysis? Risk factors for mortalities in our dialysis patients, how social determinant of health contribute to these outcomes. A lot of our dialysis patients aren't eligible for the different trials for medications like remdesivir and tocilizumab. They weren't included. And also, again, the vaccine efficacy, whether our dialysis patients weren't included in those trials for vaccine, and we still don't know whether or not they're going to form an antibody response to that. And so that, I'm just going to end with thanking all of my mentors and lab members and collaborators who participated and mentored me throughout with all of these research projects. And I'll take any questions.
Thanks so much, Dr. Chen. Wonderful talk. I think there are some questions being entered in the chat. I can sort of read one. The first one is from Dr. Dua, just asking about the hypercoagulable state, and are we recommending prolonged post-hospital discharge anticoagulation in these patients?
I don't know what our hospital is doing right now, actually. I think initially we were, and I've done a little bit of reading about whether or not they should be or should not be, and it seems like the consensus is still not clear because readmission patients are getting readmitted for bleeding risk, but then patients are also getting readmitted after starting AC with bleeding. In our dialysis patients, it's actually even trickier because dialysis patients are higher risk for bleeding. So I would say that I don't think there's actually been studies out there specifically in this population, although it's a really good question that we should look into. But because they're inherently higher risk for bleeding, I don't think we should be. But that's my opinion, and I'm not an expert in anticoagulation.
Yeah, Dr. Dunn responded that we do not recommend anticoagulation after discharge, and the AC policy was recently revised. I don't know if Andy wants to unmute and chime in to expand. Yeah, if not, there's another question from Dr. Sherman, just asking about how much of the kidney function deterioration is due to cytokine storm, and if the vaccinations may decrease the renal effects.
So it's whether or not the AKI is due to cytokine storm. It certainly can be a contributor. There were some reports of TMA, which may be related to the cytokine storm. There's also IL-6 is inherently related to the different pathways in the kidney, like STAT3, which we have also started to look into, and there seems to be elevations in those pathways. But I think there's so many potential mechanisms of AKI that it's hard to exactly pinpoint which is which. And even of our patients who were biopsied with like different GNs, there's often tubular injury on top of that. So I think it's difficult to exactly say how much is each contributing to each. The counter to the cytokine storm argument is that, again, our patients actually have altered immunity, so they aren't able to mount the same immune response as non-dialysis patients, looking at that population, but yet there's still quite a high mortality in those patients too.
Right. Excellent. And another question is if you have or are aware of any data on the AKI incidence for COVID patients who are not hospitalized.
We don't have that much data on them because they don't necessarily have blood work done at the same time. And there have been a couple patients that have kind of trickled into our system who had random GNs very soon after their COVID infection has improved. So I think there's of the patients that we do biopsy, they're like IgA nephropathy and some other things, but we don't have as much of a clear picture in that population yet. And they may also have had transient AKI, which would have improved by the time they actually came to get their blood work done.
Yeah, hopefully the data from the Center of Excellence and the patients who are followed up, many of whom are not hospitalized, will shine some light on that. And Dr. Dua clarified that she was asking about the potential interaction between thrombosis, right, and the risk of AKI, CKD progression, ESRD. Any thoughts on how thrombosis may play into the progression of kidney disease?
Thrombosis. So I'm just reading her question on the chat too.
Okay.
So our ESRD patients, we were working with a fellow to look at whether or not their access tended to be clotted, because there was a question of when they were hospitalized, there was increased rates of catheter thrombosis and also vascular fistula and graft thrombosis. We're still working on that, but preliminary, I don't think we have actually found anything. For AKI, even more risk for thrombosis. There was initial reports about TMA, and we had a couple of patients who ultimately had autopsies done who had PEs. Then there was clotting in the kidney, but TMA outside of that has not, I think, been that frequently reported.
Right. And Dr. Chen is asking, just mentioning that monocytes are predictive in the model, and he's asking how inflammation of the kidney may relate to the mechanism of disease.
That's a really good question, and I don't think I have a good answer for that. Whether or not that's just overall inflammation, because if you just look at monocytes, that's one thing, but like the lymphocyte percentage, which was also it's often cited as a risk factor, wasn't actually different in our model, whether or not they developed severe dialysis or not. There was no difference with that, and also comparing the different inflammatory markers. Obviously, the patients who did have AKI did have higher inflammatory markers too. But again, we don't have a lot of biopsy samples of the patients who did develop AKI. Unfortunately, right now, I think that was the one person I talked about in the presentation was the person that we had. But I feel like it's just so much still to be learned from this, and that we just don't have an answer to a lot of these questions, but hopefully we will in the future.
Yeah. There was a question about whether we know if patients who are vaccinated, right, in the Moderna Pfizer trials, if the vaccination decreased the renal effects or complications, right, from those who got COVID-19. Do we have any information on it?
We only know that from end of December, while the second surge happened kind of end of November into December, the AKI went down, but by that point, vaccines hadn't really occurred yet, at least in the general population. So I think we're going to have to kind of look at that over time over this next year as more people are vaccinated to kind of figure out. But right now, I don't think enough people are vaccinated to be able to contribute significantly to any changes.
Yeah, perhaps more widespread use of steroids and other protocols could have decreased that effect. All right, and a question is, did the fact that the patients were on ACE or ARBs affect kidney outcomes in COVID-19 patients? The whole ACE2 question.
I think we looked at that. I'm trying to remember exactly what it was because I think I have a slide looking at the different medications that they used, and there was no difference in whether or not they were on, as an outpatient on ACEs or ARBs between those who developed AKI and those who did not develop AKI. And I think right now, and general consensus from the nephrology community is that if they're on it, they should continue on it throughout the pandemic, because the risk of hypertension would be much worse than the ACE risk.
Yeah, the benefits outweigh the risks, right? Yes, there's a question from your boss, Dr. He, asking if you have data on proteinuria hematuria in the second surge of COVID-19 patients.
We don't yet, but I'll take that as a direct order to look into that.
All right. And yes, another question relating to the use of steroids. Is the routine use of steroids in treating COVID patients reducing the incidence of AKI in the second surge?
So far we've only looked at the incidence of AKI and dialysis, and we haven't looked at what were the contributors to differences in incidence. I certainly think that improvements in our treatment protocols and also changes in the patient population are large contributors to these differences. But we're going to look into that a little bit more. We just right in the beginnings, I feel like, of the second surge, so we still have to kind of see how things pan out.
So the one question on the socioeconomic status analysis by zip code, I think one of the limitations that you foresee, right, with that strategy, different household incomes within zip codes, I think how challenging is it to do that type of analysis?
So I think New York is uniquely in that our populations are so mixed that even within the same zip code, we can have someone who is a CEO or a financial analyst and someone who is just single mom with a much more socioeconomic challenge. And that's why we're actually not going to be depending on zip codes solely. It's actually going to be geospatial analysis down to nearly a street level with a 1 mile radius. And we're working with someone from Colombia and also internally to kind of do that analysis. Once we have their addresses, we can create even smaller than zip code tracks to look at the different social determinants of health within that neighborhood.
Excellent. Any other questions? Feel free to unmute or type. If not, I'd like to thank Dr. Chan. Excellent presentation and great discussion. Thank you so much.
Thank you, everyone.